Good morning, everyone, and welcome to a podcast that's dedicated to the OASIS Q&As that were put out in April of 2022 by CMS. Every quarter, the OASIS office at CMS, if you will, the OI or is it the QIOS, Cindy, they put out a Q&A based on the questions that they get. I would think that this year, Cindy, it's been relatively quiet for the Q and A's. Typically, you see more than two questions on the Q and A's, and it seems a little bit thin. But I think maybe it's because we're preparing for OASIS E. Cindy, how would you summarize what information we were given for the April edition of the Q and A's?
Well, although it's short, much like the one was in January, there are still important clarifications in them, and it kind of concerns me that you're right. I think there are less of them because we're shifting our focus to OASIS E and waiting to see what new and exciting questions come about from new items. But there are some things we have to make sure we pay attention to. And recent results of our OASIS knowledge assessment test indicate that Q&A information is not necessarily making it down to the front line with any degree of speed. I mean, our current test included items related to both the January Q&A and the preceding one at the end of 2021, and those questions are being missed at a very high rate. So I think my concern here is that, and prompting this podcast is we can't just get very passive now and think we're coasting into the end of the year till we take on E, because when you look at some of these clarifications, some of it is familiar information, but there are a few nuggets that I really want to hone in on today. And again, I'm not only, Sherry, I'm not a slide reader. I'm also not a Q&A verbal reader. There's no real value, in my opinion, to just read this back to people. We want you to look at the document yourself, to be very familiar with it, but there are some highlights I wanted to pick on today. And the first category they went after had some things to do with time points. The first question might be familiar territory for many, that if we have a quality episode and end up with only one visit in it for whatever reason, the question usually is, do I have to submit the OASIS for this? And they consistently come back with, you can submit the OASIS for this. So it really comes down to an organizational decision about if we really, at the end of the day, only ended up with this OASIS time point. In the case of the example they gave is they had done a rock recert at the last 5 days of a cert period, and then into the next episode, the patient had passed away without getting any visits. Do you have to fill out a death at home? Again, you can fill it out. You can submit it according to CMS, but you can also just keep it and the rock recert as a paper trail, as it were, in your EMR for record purposes and not submit it. So again, it's not a definitive you have to do something here, but it's something that we need to be thinking about from an organizational process standpoint. What are we going to do with that information in those situations? The second question is where newer information is coming up again with respect to this timing issue of death at home. That came out the end of 2021 because there was some concern about the upcoming quality measures about transfer of medication-related information to the next facility, about what about patients that go to the hospital and pass away in the building. Historically, what do we do with this? Is it a death at home? Is it not a death at home? Because if I put transfer to an inpatient facility and they pass away there, okay, but am I still held to, I have to transmit the medication related information to the next setting? Am I really going to have to send essentially med sheets to the hospital when the patient has passed? That was a very interesting Q&A update that said, effective immediately, which is usually not the case, but talks about the timing issue. So they kicked it up a notch with these April questions about an individual who went to the hospital but was kept in observation status and passed away. The directions there were clear that that is considered a death at home time point. And the only time we're using that transfer to an inpatient facility and then the decision of whether or not, we're keeping the case open or discharging them as well, is a qualifying hospital stay. So that is being actually admitted to the hospital for more than 24 hours for something other than testing. So yes, the clarification we got in late 2021 was if a patient was admitted to the hospital, so we're not observation status, but admitted to the hospital and passed away less than 24 hours later, what are we supposed to do? That is also now a death at home. And I think that's been one, Sherry, that hasn't really gotten dispersed far and wide. And it probably doesn't happen a lot, but given the direct impact on a measure that we're accountable to about transferring information, I think it's important, one, that agencies pay attention to of this timing of when a patient goes to the hospital and passes. What form am I really required to do? Because that will impact me in the end. The next section got back on the medication train, and anyone who looked at the January Q&As, it was kind of like, okay, was this really a bunch of different people asking the question, or was it the same person asking the question multiple different ways? And each time they asked the question, it looked almost like a cut and paste response from CMS about what to do here. And the bottom line was, when you're assessing item 2020 and 2030, what about a patient who does not have all of the oral medications or the injectable medication in the home at the time of the assessment? And what they said in January is that you can utilize your full scope of assessment skill to interpret potentially that this patient, if the medication was here, since they're doing all of their other medications fine, or they have a pill planner and they know exactly how to use it, and so once this medication arrives in the home, it would just go into the rotation, and I don't see anything physically, cognitively, environmentally that causes me any concern, I can say that this patient has a process that's working. So I can choose response 0, 1, or 2 for a patient, even if the medication isn't necessarily in the house. Keep in mind, again, they didn't say you have to, they said you can. So if there's anything causing us anxiety about, I don't think that's necessarily going to work well with this medicine because they're already messing up the ones they have, then I am able to choose responses saying, listen, even if that one was here, it's going to be a problem. Now, it upped the ante a bit with a different angle in these Q&As by saying, well, what if the patient is missing doses because of a transportation issue? So again, it's kind of an extension on the medication isn't always in the home when it needs to be. And the reason is transportation problems in getting the medication. And this is where I was telling Sherry before we hit record today that this is, again, a wonderful example of how the OASIS is discipline neutral data collection. We got to stop putting the clinical baggage on it, because that's not what this is. Because the response to the what about transportation was clearly transportation, the ability to get the medication to the home, is not part of this question. And I think that, hurts the hearts of clinicians everywhere, saying, you've got to be kidding me. What do you mean it doesn't matter about the medication? It's not a judgment. It's not CMS saying, I don't care if they don't take their medication. It's saying that for the parameters of data collection, whether or not it's transportation affecting a dose, that's not what this question is. This question is about their ability to get all ordered doses into their body correctly. So transportation is not considered here. A missing medication, you can extrapolate based on what you're seeing to what you think would be true for that medication if it was physically there. But what bothers me more than anything else is, okay, it's data collection, straightforward answer, got it, everybody can rejoice. What the Q&As fail to do, and what I feel compelled to do, is to say, that's fine, your understanding for items 2020 and 2030, but the missing medication may be what ends up in your item 2001 and needs to be given clear consideration about these missing doses, especially in the example question that talked about missing several oral and an injectable medication. Does this rise to the level of a clinically significant medication issue? And so, yes, I may need to deal with 2020 and 2030 from these parameters of medications in the home or not. But we got to think bigger too, and say, if patients are missing doses for transportation reasons, or they left it at the nursing home and didn't take their blood pressure medicine for the last 2 days because they haven't gotten it back yet, that absolutely can rise to a clinically significant medication issue that we need to report in 2001. And yes, that means we have to deal with the two-way communication with the physician in one calendar day. but that's important information. And so we want to make sure we're thinking about that element as part of our medication assessment. They did dabble again in what do you do with the patients in the ALF? Could you ever score a patient in the ALF as a 0 for medication management? And clearly they state there's nothing about the ALF itself that drives a response choice. But it does say that if the patient is able to get to their medication in the ALF, know what they're supposed to take and when, and self-administer it without any involvement of anybody else, then you can potentially score them a 0. So they're referencing, like, if where the medication is kept in the building, a staff member just needs to unlock it or open the door so they can get in there and get it, and basically opens the door and leaves them to do their medication without any sort of, cues or anything like that, you could call someone in the ALF independent with the medication. So Sherry, the last one I thought was, again, a great example of discipline neutral data collection, because it was talking about a patient who is independent with feeding themselves, but needs encouragement to increase their food intake. Did this somehow fall into assistance in the GG question about eating? And the CMS response was no. That question is about the ability to feed yourself. It is not about the quality of your nutritional intake. So again, clinical, no, that's wrong. I mean, they need the cues, they need to eat better, they need to eat different. Isn't that somebody involved with the eating? No. And there can be a very valid clinical reason that we're going to be doing that and encouraging the family or caregivers to give that kind of cue, but that is not what that GG item is about. It is about the ability to feed yourself, not the nutritional quality of what you're putting into yourself. So Sherry, I just think these Q&As are good examples of, one, tidbit things we do need to pay attention to. We can't just ignore the Q&As and wait for OASIS E because we could miss something significant. And we got to make sure that we may know them as a leadership level or in the review department, but how well have we communicated that to clinicians? Because the data collectors need the information. That way they collect it right the first time, and we don't have to deal with correction process either way. So I hope that was helpful. And Sherry, you want to tell them a little bit about where we're going with this Q&A update idea?
Thanks, Cindy, for that helpful information. I think that agencies need to have some of this explained out in real terms, and not get confused with the way that some folks will, like I think you mentioned that folks will ask questions and then they'll ask them in 14 different ways and trying to elicit a different answer from CMS. So don't
Mhm.
get confused by that. We're anticipating that the Q2 and Q3 OASIS Q&As are going to be pretty darn uh, robust as we edge closer to OASIS E. 237 days left to prepare, guys. And we have partnered with the Ohio Home Care and Hospice Association. And Cindy, could you tell the exact name of that institution, because I've gone blank?
Well, I don't have it up. It we'll
It's
make sure there's an
Ohio.
update. It's the
Ohio.
Ohio Home Care Association.
It's the
You can
Ohio Home
find it.
Care Association, and
Yeah.
we will be blasting out the information on this, because we're going to partner with them to get to as many states and as many individuals and as many clinicians the webinar on the next two Q&As as we get prepared for OASIS E in on 1/1/23. So guys, look for that, and that will be much more of a long format, and we probably will have the opportunity for some Q&As in the chat box and in the Q&As on the webinar. So we look forward to offering that through Ohio, and look for the links in our emails. Thanks, Cindy.